this module, I am going to discuss about Pediatric Advanced Life Support Guidelines or PALS guidelines. This is in accordance to the latest set of guidelines given by AHA, which is American Heart Association, in the year 2020. Now let us start discussing about that. When are you supposed to start this advanced life support in pediatrics? It is during situations of cardiopulmonary arrest. Okay. Please remember that the reasons or cause for cardiopulmonary arrest in children is more respiratory than cardiac. Cardiac causes are more common in adult, whereas in children, respiratory causes are more common. The usual common causes include respiratory conditions like respiratory failure, number one. Number two, it could be the terminal stage of shock. Terminal stage of shock. That is the next condition where you can have cardiopulmonary arrest. Okay, these are the two usual scenarios. Now, first I will tell you about the details of steps in cardiopulmonary resuscitation. Then I will tell you about the algorithm of cardiopulmonary resuscitation. So what is that overview of CPR or cardiopulmonary resuscitation according to the guidelines? It is in 3 stages. One is assessment, initial assessment, then circulation, then airway, followed by breathing. This is the order which is usually followed. First, starting with assessment. Assessment is to confirm that the child is actually in cardiopulmonary arrest. How do you do that? You go beside the child, just tap on the child and keep asking, "Hey kid, are you okay?" Something like to confirm that the child is actually not responsive. And 2 important things you are going to assess simultaneously. What are the 2 things? One is circulation, assessment of circulation by looking for a pulse. Other one is breathing by looking for the chest movement. And please remember, it has to be done within 10 seconds. Both circulation and breathing assessment should be done simultaneously and within a period of 10 seconds. This is just to confirm that the child is actually in cardiopulmonary arrest. This is the very first step. Once you have confirmed, the next step is in the circulation. Okay. Now, how do you take care of the circulation during CPR? It is by starting chest compressions. Without any doubt, it is by chest compressions. There are certain principles of chest compression that one should be aware of. One is about the technique and some points regarding the chest compression. Let us start with the technique of chest compression. As you can see in the picture, the first technique is where you encircle the child's chest and press with 2 of your fingers over the lower 1/3 of sternum. This is what we call it as a 2-thumb technique, which is recommended in a child less than the age of 1 year. I hope you can recollect that this is the same technique I told for neonatal resuscitation, and that applies for a child in infancy or less than 1 year. The second technique is what you see here. You can give chest compressions with your one hand. What do? You keep the base or heel of one hand over the lower 1/3 of the sternum, and then you give chest compression. This is advised for a child between the age of 1 to 8 years. Okay, so using your base or the heel of one hand. What is the next technique? This is done for a child more than the age of 8 years or for an older child, where you use both your hands. Okay, you interlock the fingers of both the hands, keep it over the lower 1/3 of sternum and press with the base or heel of both the hands together. This is similar to what you do as chest compression in adult age. Okay, so these are the three different techniques of giving chest compression and depending on the age of the child. Next is about some other points about chest compression. Please remember that when you do chest compression, remember these two things: push hard and push fast. Don't forget this. Okay, push fast. How fast you have to push? At the rate of 100 to 120 per minute. Very, very important. And every time when you press, you should allow full recoil in between the compressions. Very important. Allow full recoil of the chest in between the compression. This is important. Okay. Second is, how much is the depth of insertion? It is up to 1/3 of the antero-posterior diameter of the chest. That is the depth of insertion. And what is the site? Of course, I was telling that before also. It is in the lower 1/3 of the sternum. And very important, you should avoid the xiphoid process. Can be easily injured. That is why you should avoid the xiphoid process and press over the lower 1/3 of the sternum. These are the important aspects of chest compression during CPR. Next is about airway. By airway, I mean measures to keep the airway patent or open to aid in the process of breathing. How it can be done? This is by two maneuvers. One is called as the jaw thrust, and the next one is head tilt and chin lift. Okay, to understand it better, please have a look at these pictures. This picture depicts the jaw thrust maneuver. What you do, with fingers of both your hands, keep them behind the angle of the jaw and try to lift the jaw upwards and slightly outwards. That is what is called as the jaw thrust. Okay, so with the fingers kept behind the angle of the jaw and try to lift the jaw upwards and outwards. This is what is called as jaw thrust. Okay. The next one is head tilt and chin lift. With one of your hand, you press on the forehead and slightly push it back. That is what is called head tilt. And with the fingers of your other hand, keep it in the jaw like this and try to lift up. That is what is called chin lift. Okay. Now, an important point to be noted regarding this head tilt chin lift maneuver is you have to avoid in head and neck trauma. Why? Because there could be a possibility of cervical spinal cord injury or cervical spine injury, and that would be exaggerated by this maneuver. That is why in head and neck trauma, this maneuver has to be avoided. So these are the practical aspects of airway management during CPR. The next aspect of cardiopulmonary resuscitation is to provide manual breathing. It is also called as assisted ventilation. Manual breathing is also called assisted ventilation, and this can be done by two ways. One is a non-invasive form, which is bag and mask ventilation, and the other one is the invasive form, which is usually done by endotracheal intubation. I have discussed about various aspects of bag and mask ventilation in the neonatal resuscitation module, so please refer in case you have any doubts regarding bag and mask ventilation. There are few differences with regards to endotracheal intubation, which I am going to discuss it here. First is regarding the size of the endotracheal tube to be inserted. Size refers to the inner diameter of the endotracheal tube. This can be calculated by a simple formula, which is age of the child in years divided by 4 plus 4. This should tell you about the approximate size of the endotracheal tube to be inserted. Number 1. Number 2, what type of endotracheal tube to be inserted? Very important is according to the present PALS 2020 guidelines, it is cuffed endotracheal tube which is to be inserted. Cuffed tube. What is the advantage of using a cuffed tube? It will help to prevent the air leaks as well as decrease the number of times the tube has to be changed. That is why cuffed tubes are now being recommended. Okay. Only important point to be noted is when you inflate the cuff, the pressure in the cuff should be less than 20 to 25 centimeters of water. That is the only requirement which has been said, because if you keep high pressures, there is a chance of pressure induced tracheal necrosis. That is why pressure should be kept in the lower range. Okay. Third is regarding the depth of insertion. Again, there are some formulas to calculate the depth of insertion. First formula is 3 into size of the tube, endotracheal tube. For example, the size is 3. The depth of insertion should be 3 into 3, which is 9. It is expressed in terms of centimeters. So for the example I was talking, it is 9 centimeters. Or another better way to calculate the depth of insertion is by another formula, which is age of the child in years by 2 divided by 2 plus 12. That is also another important way by which we can calculate the depth of insertion. Now, in the updated PALS 2020 guideline, there are certain important facts which have been given, which are to be followed from now on. Number 1 is regarding the routine use of cricoid pressure during endotracheal intubation is not advised or not recommended. Very important. Okay, that is the first thing. Second thing which they have recommended is the rate of breathing or rate of ventilation. Okay, it is 20 to 30 breaths per minute. 20 to 30 breaths per minute, which is roughly 1 breath every 2 to 3 seconds. That is the second recommendation. And third important thing is naloxone should not be used routinely for all babies with respiratory depression, only if there is a definite history of opioid overdose, then it can be administered. Otherwise, naloxone administration is not a routine procedure. These are important things which have been emphasized in 2020 updated guidelines. Okay. And one more thing also has been emphasized, that we were talking about 2 types of assisted ventilation, bag and mask and endotracheal intubation. What they have said is out of hospital cardiac arrest, that is outside the hospital, if the cardiopulmonary arrest occurs, bag and mask ventilation is equally good as endotracheal intubation. So you don't need to wait for an expertise to put the endotracheal tube and start ventilation through an endotracheal tube. Bag and mask ventilation is a good enough procedure in out of hospital cardiopulmonary arrest. That is also mentioned in the updated 2020 PALS guidelines. One more important aspect of resuscitation is to secure a vascular access for administration of medications like epinephrine. Okay. Now the recommended vascular access is intravenous access, IV route. That is what is recommended, and it is always preferable to have a large vein or large accessible vein to be used. Large accessible vein to be used. And what is that commonly used vein? It is the femoral vein. Okay, that is the usual vein which is taken up for the purpose of vascular access in resuscitation. Suppose you don't get an IV access, then what is the alternative? You can go for intraosseous, IO, that is intraosseous access. This picture depicts how to get an intraosseous access. As you can see, the preferred site of bone for intraosseous access is the tibia bone. This is the area of tibial tuberosity as it has been marked. You have to insert the needle below and medial, just below and just medial to tibial tuberosity. The main point to be emphasized here is the first 1 to 2 centimeter. Can you notice that this is the first 1 to 2 centimeter part of the bone which has to be left undisturbed. Why? Because in that 1 to 2 centimeter only you are having the growth plate, and if that is going to be injured at the time of intraosseous access, it can interfere with the growth potential of the child. That is why we will always leave the first 1 to 2 centimeter of the tibia bone and insert the needle below and medial to tibial tuberosity. Those are the important points regarding intraosseous access in case you don't get an intravenous access. Having discussed about the various steps of cardiopulmonary resuscitation, now let us look at the algorithm or the protocol of CPR. You're going to start CPR in an unresponsive patient. As I have said before, the first thing is the assessment of the unresponsive patient, which includes checking for the pulse and breathing simultaneously within a time frame of 10 seconds. Okay? And based on this, you can have two scenarios. One, where the patient is not having any pulse as well as the patient is not breathing. That is the first scenario. The second scenario is the patient is having a pulse but no breathing, absence of breathing. That is the second scenario. Let's start discussing the first scenario where there is no pulse and no breathing. This is an immediate indication for starting CPR. Remember, you have to give high quality cardiopulmonary resuscitation, which is a combination of ventilation as well as compression. Always remember the principle I told you for chest compression. Push hard and push fast. Don't forget it. So, compression, that is chest compression, along with ventilation has to be done at this point of time. Now, what is the ratio between compression and ventilation? This is an important question as well as something which we need to know at the time of resuscitation. It depends on how many rescuers are available for resuscitation. Suppose you are the single person or the lone rescuer, then compression ventilation ratio is 30:2. 30 compressions and 2 ventilation. Suppose there are 2 rescuers available for resuscitation, then the ratio would be 15:2 because they can coordinate better. So remember, ratio will vary according to number of persons available for resuscitation. As you continue giving CPR, reassess after some time. Usually reassessment is done after 2 minutes or after completing 2 cycles of compression ventilation, and at this time you have to attach AED. What is AED? It is automated electrical defibrillator, which should be attached to the patient. This is something which is available even in public places like in railway stations. So usage of AED is something that every medico should be knowing about. This is a picture of automated electrical defibrillator and the way in which it is attached to the patient. It has got 2 pads which are attached over the patient's precordium, exactly like what I have shown in the picture. What is the main role of AED? Once you attach it, it will display the rhythm, and based on the rhythm we can make further decisions. So after attaching the AED, you have to assess the rhythm. We can divide the rhythm into 2 types. One is the shockable rhythm, other one is non-shockable rhythm. let us look at how the rhythms will look like in the EG. Just try to identify the rhythms from the picture I have put up. The first picture is a rhythm of very irregular activity called as VF, which is ventricular fibrillation. Okay. How did I identify that it's a ventricular fibrillation? Basically because it is an irregular rhythm, number one. And number two, you can see that there are broad QRS complexes. Always remember, broad QRS arrhythmias points to ventricular arrhythmias. That is a point to be noted. Now, look at the third picture. The third picture is again broad QRS complex, but it looks more regular rhythm. And this one is VT or ventricular tachycardia. Because you are encountering ventricular tachycardia at the time of cardiac arrest where the patient doesn't have any pulse, this is called as pulseless VT, or in short form remembered as PVT. What is the importance of knowing these two rhythms? These two are shockable rhythms. Don't forget, these two are shockable rhythms. Okay? Yes. Now look at the other two ECGs where you have a flat line. In the second picture, you're having a flat line. This is what we call it as asystole. Okay. And the last image, you can see that there is some electrical activity like this, but it is very, very occasional electrical activity. But remember, we are looking at a patient who is in arrest or heart rate is 0 in that patient. So even though there is no heart rate, still there is some rhythm which is noted. What do you call this? You call it as PEA or pulseless electrical activity. Okay. And please note that asystole as well as pulseless electrical activity are non-shockable rhythms. This is something which we should definitely know about. These are the different rhythms which can be encountered during the time of cardiopulmonary arrest. So coming back to the algorithm, if it is a shockable rhythm, you should give the shock with the help of AED. The usual amount of shock which is given is calculated in terms of joules per kilogram. Usually it is 2 joules per kilogram. J here stands for the joules, which is the amount of shock being delivered. Okay, so give one shock through the AED itself and then you continue CPR. Then again assess after 2 minutes of giving CPR. If there is no response, then again you can repeat one more shock. However, please remember the maximum amount of shock which you can deliver to a patient during cardiopulmonary resuscitation is up to 10 joules per kilogram. This should always be remembered. Okay, that is about the algorithm for a shockable rhythm. What about algorithm for the non-shockable rhythm? Obviously, you cannot apply shock, so your logical thinking is to continue CPR. But this is where the changes have come. Before you continue CPR in a non-shockable rhythm, you give first epinephrine dose. Okay, you give the first dose of epinephrine. How is epinephrine given? Epinephrine is given as an intravenous route. The usual dose is 0.1 ml per kg. Most important thing to be remembered is the strength of the adrenaline solution, which is 1 in 10,000. Don't forget it. Okay, right? Now remember, this is a major update because previously epinephrine was administered in the last steps of the resuscitation. But now it is little early in the resuscitation steps, which should be remembered. So non-shockable rhythm, give epinephrine immediately as early as possible. This is because it is found to have a good outcome when compared to late administration of epinephrine. Okay, and after giving epinephrine, you have to continue CPR. The other principle will apply that after you continue CPR, analyze the rhythm or reassess again after 2 minutes and make further decision. Okay, that is about the algorithm for a non-shockable rhythm. So this tells you about the usual algorithm which we follow whenever patient in cardiopulmonary arrest does not have a pulse and does not have a breathing effort. Now coming to the other side, that is patient is having pulse but no breathing effort. Here the obvious step is to start rescue breathing. Usually started with bag and mask ventilation. What is the rate of rescue breathing? I have told that before itself. It is 20 to 30 breaths per minute. It is very important that after starting rescue breathing, you should reassess the patient every 2 minutes. And at any point of time, if the patient's pulse is negative, that means there is no pulse, or if the heart rate goes to less than 60 with signs of poor perfusion, then you have to move to CPR step. Okay, that means you have to immediately start CPR at any point of time if the patient becomes pulseless or the heart rate is less than 60 but with signs of poor perfusion. One last thing about resuscitation is whenever you are doing resuscitation at any point of time, you have to look for the reversible causes or correctable causes. They are usually remembered as 4H and 4Ts. For example, the 4H include hypovolemia, hypoxia, hypothermia, and hyperkalemia. Very important, hyperkalemia. These are the 4H that you should be knowing about. Next is about 4Ts. These Ts include tension, pneumothorax, tamponade. I am talking about the cardiac tamponade. Then about toxins or drugs causing cardiac arrest. And finally is thromboembolism. What I am referring to as a thromboembolism is the pulmonary thromboembolism. So whenever you detect any of this cause at any point of time during resuscitation, you have to correct it. So these are the detailed steps or algorithm of cardiopulmonary resuscitation according to PALS 2020 guidelines. Another important aspect of PALS 2020 guideline has been on the emphasis given to post-resuscitation care. That is, once the patients are having a return of spontaneous circulation following successful CPR, what are the things you have to monitor and correct? These include maintenance of blood pressure, number 1. Number 2, correction of hypoxia. Number 3, correction of carbon dioxide problems like hypocapnia or hypercapnia. Number 4 is targeted temperature management. This is a relatively new concept that you should be aware of. It is basically decreasing the body temperature to the range of 36 to 37.5 degrees centigrade. Why so? Because decreasing the body temperature decreases the metabolic activity in the brain and can help in the recovery of brain in case the patient has suffered any brain damage during the course of cardiopulmonary arrest. That is the logic behind inducing hypothermia in the post-resuscitation stage. That should be remembered. Next is regarding continuous EEG monitoring. Okay. This is also important because it is found out that many patients, once they recover from the cardiopulmonary arrest, they have ongoing seizure activity without external manifestation. That means what? Many of the patients have non-convulsive seizures, which can only be picked up by EEG. That is why continuous EEG monitoring is needed. And when any seizure spikes are noted, it has to be treated accordingly. Okay. The last part of this post-resuscitation care is delaying the prognosis for 72 hours after the event. Why 72 hours? Because it is found to have a good estimate of the outcome rather than giving the prognosis in the first 72 hours itself. So what you do in the typical setting, you give a guarded prognosis in the first 72 hours, and after 72 hours, depending on the different vital parameters, you can give a good assessment of outcome in that patient. So that is the importance of delaying prognosis till first 72 hours after the event. So this is all about cardiopulmonary resuscitation according to PALS 2020 guidelines. So this will be about the summary of important points as well as some updates according to the 2020 guidelines. Remember, high quality CPR is the foundation of resuscitation. Don't forget, push hard, push fast. Next thing is regarding the breathing. At the time of manual breathing, you have to maintain a respiratory rate of 20 to 30 breaths per minute. And what is the next update? For patients with non-shockable rhythm, always earlier epinephrine is recommended because that results in a good outcome. And as per the present guidelines, always used a cuffed endotracheal tube. The next one, routine use of cricoid pressure is never indicated in pediatric resuscitation. And please remember, out of the hospital cardiopulmonary arrest, bag and mask ventilation is as good as endotracheal intubation. And the last point is excellent post-cardiac arrest care is critically important, where we monitor the vital parameters of the patient as well as important functions including neurological functions. So that is about the summary of PALS 2020 guidelines. Now I am going to discuss about tachycardia and bradycardia algorithm according to PALS guidelines. First, I will start with pediatric bradycardias, which is defined by heart rate of less than 60 per minute. Okay. Now, before we start treatment for bradycardia, there are few basic things which you need to take care of. Okay. First thing is, if possible, try to look for a usual cause of bradycardia, and if you find out a cause, you have to treat the cause. The common causes includes conditions like hypoxia, hypothermia, and medications. If any of this is present, you have to treat accordingly. Second thing, you have to maintain the airway. Maintain a patent airway. Very, very important. If the child is stable, make the child to assume a comfortable position where he or she can maintain the airway. Or if the child is unstable, you have to secure an alternative airway. These are the things which should be always be remembered. Third, oxygen support should be given only if it is necessary. For example, child having significant hypoxia, oxygen support is important. Fourth, you have to connect a cardiac monitor and continuously assess the vital parameters like the heart rate and the blood pressure. Fifth, you have to get an intravenous line. If intravenous line is not available, you have to get an intraosseous access. IO is intraosseous access. Okay, and always at this time you have to connect a 12-lead ECG. These are basic things which has to be done in any child with pediatric bradycardia. After having done all the basics, you have to do the next step, which is to check for signs of poor perfusion. Very important. Check for signs of poor perfusion. These signs include altered mental status, low blood pressure or hypotension, or child having features of shock. any of this is present, it is considered as signs of poor perfusion. Suppose child doesn't have any of these signs, there are no signs of poor perfusion, or in other words, the child is stable, you need to do close observation of the child. That is all which is recommended. And again, at any point of time, if you can find out a cause, you have to treat it accordingly. That's all. Suppose the child is having signs of poor perfusion. Yes, there are signs of poor perfusion. Then what are you going to do? The first thing to be done is, again, airway. Airway should be secured and oxygen should be provided if needed. Okay? And if the child is not breathing properly, then you may have to provide positive pressure ventilation as well. So important thing is immediately oxygenation of the child. Okay, suppose child is not showing a response or no improvement even after adequate oxygenation and heart rate still is less than 60 per minute, then you have to start CPR, cardiopulmonary resuscitation. Remember always to provide high quality CPR at the rate of 100 to 120 chest compressions per minute. Very important, always allow full recoil in between the chest compressions. As I have said before in the previous module, you have to do chest compressions at the lower 1/3 of the sternum, avoiding the xiphoid process. These are the basic steps in high quality CPR. Even after doing high quality CPR, the patient remains in bradycardia. Okay, the patient remains in bradycardia. What are you supposed to do next? Okay, you have to administer medications at this time. The commonly used medication is epinephrine. Okay. We all know the action of epinephrine. It's both alpha and beta agonist. By beta agonist activity, it will improve the contractility and the heart rate, and alpha agonistic activity causes vasoconstriction. Okay, the usual dose of epinephrine by intravenous or intraosseous route is 0.1 ml per kg, which is corresponding to 0.01 milligram per kilogram. And always remember what is the strength of the epinephrine solution. It should be 1 in 10,000 solution. Very, very important. And if there is no response to the initial dose of epinephrine, you can repeat after 3 to 5 minutes. Okay, right. Another drug which can be useful in the situation of bradycardia is atropine. We all know about the action of atropine. It enhances AV conduction. Okay, that is why atropine is more useful in cases of primary AV blocks, and also atropine having an anticholinergic action is useful in condition where there is a high vagal tone. These are the conditions where you prefer atropine over adrenaline or epinephrine. The usual dosage of atropine is 0.02 milligrams per kilogram. Please note some important points here. The minimum dose has to be 0.1 milligram and the maximum dose is 0.5 milligrams. Okay, that's an important point to be noted. Now, you can repeat one more dose of atropine if there is no response to the first dose. Okay. Suppose you have a patient with AV block and he is not responding to atropine. Okay, so the situation is AV block or heart blocks and there is no response to atropine. You have given the second dose of atropine also, to which there is no response. This group of patient is going to benefit from pacing. Okay. There are two ways by which we can do this pacing. One is transthoracic route and the other one is transvenous route. So this is the next treatment option which is available. So that is about the algorithmic management of a child with bradycardia. We will now move on to the algorithmic management of tachycardia according to PALS guideline. Remember, any child with tachycardia, you have to do the basics correctly. That is, you have to support ABCs, that is airway, breathing and circulation, as I have discussed before. Provide oxygen if it is necessary, and at this time you have to attach a cardiac monitor or defibrillator. Okay, and continue to assess the child. Suppose even after doing the basics, the child continues to be in tachycardia present even after doing the basics, then you have to go for specific evaluation. At this time, you have to attach a 12-lead ECG and analyze the rhythm. Okay, you have to particularly focus on the QRS duration. We can have two types of tachycardia based on the QRS duration. One is a narrow complex tachycardia, which is characterized by QRS duration of less than or equal to 0.08 seconds, or a wide complex tachycardia, which is characterized by QRS of more than 0.08 seconds. First, let us look at the scenario of narrow complex QRS tachycardia. Okay, there are two possibilities here in narrow complex QRS. One is sinus tachycardia, which is a less severe form, and other one is PSVT. What is that? It is paroxysmal supraventricular tachycardia. That is what is PSVT. How to have a quick differentiation between these two conditions? First, for sinus tachycardia, remember you will have a history which is consistent with sinus tachycardia. The usual history, a child having some infection and associated fever, usually present with sinus tachycardia. In this condition, the heart rate would be less than 180 per minute in case of older children, and in infant the heart rate is less than 220 per minute in case of infants. Other characteristic features include variable RR interval, and also constant PR interval. Very important pointers. And one more important point to be noted in the ECG is P wave is definitely present and can be made out very clearly. These are features which are consistent with sinus tachycardia. Remember, for sinus tachycardia, no specific treatment is required. You just have to treat the cause of sinus tachycardia. The heart rate will automatically come down. For example, fever has to be controlled with antipyretics. Other common conditions leading to sinus tachycardia include hypoxia, for which oxygen treatment is required. Third is hypoglycemia, for which you have to treat with IV glucose. So these are the important management aspects of sinus tachycardia. Just you have to treat the cause. That is all that is required. Now moving on to the second category, that is PSVT. This is a condition which will have an abrupt onset. Okay, you will have a sudden increase in the heart rate without any specific reason, or you would have a history which is not very consistent with any one particular problem, or what I am going to write as inconsistent history. Okay, or something like a vague history. So remember, abrupt increase in the heart rate with a very vague or a non-specific history, consider PSVT. Okay, and in this condition, the heart rate is more than 180 per minute in case of older children, and in infants, it is more than 220 per minute in case of infants. And the characteristic EEG findings include, very important, fixed RR interval, very important. Please note, for sinus tachycardia, I have told you that it's a variable RR interval, but in PSVT it's a fixed RR interval. And P waves are either absent or they are abnormal. This is how the typical ECG picture will look like. You can notice some characteristic ECG findings here. One is narrow QRS complex. As you can see, there is only two small squares which correspond to 0.08 seconds. So it's a narrow QRS. Next thing, you're not able to make out a definite P wave. So P wave is absent here. And number 3, you can see that the RR interval is fixed. Okay, that is what I said, constant RR interval. This is definitely consistent with the diagnosis of PSVT. Suppose you have confirmed the diagnosis that it is PSVT, then you have to start your treatment. Before starting with specific treatments, you can consider vagal maneuvers. Okay, now the commonly performed vagal maneuvers include applying ice packs over the upper half of the face. Very important to note that mouth and nose should not be covered by the ice packs. Very important. Okay. Second important thing, don't apply excess ocular pressure because that is supposed to be implicated in retinal damages later on. So apply ice packs over the upper half of the face, avoiding the nose as well as the mouth. And also important, don't apply excess pressure on the eyes. Very, very important. Okay. In an older child, Valsalva maneuver can be performed. Okay, these are some of the vagal maneuvers which can be attempted to decrease the heart rate in PSVT. Okay, basically remember, vagal maneuvers decrease the rate of conduction, thereby decreasing the heart rate. Okay, suppose you don't get response to one vagal maneuver, you can try another vagal maneuver. If there is no response to that vagal maneuver also, then you have to go for further specific treatment. These include drugs. It's a very commonly asked question. What is the drug of choice for termination of PSVT? It is adenosine. Okay, usually given by intravenous route. Okay, now the usual dose of adenosine is 0.1 milligram per kilogram to a maximum dose of 6 milligrams. Very important. Okay. The technique of adenosine administration is rapid bolus technique, which is done with the help of 2 syringes. Through the first syringe, you will quickly push adenosine inside. And once that is done, with the second syringe, you will push normal saline 3 to 5 ml. Why this is done in a very fast manner or a rapid manner is because adenosine has a short half-life. Very important. Suppose there is no response to first dose of adenosine, that is, the patient still continues to have tachycardia, then you can give the second dose of adenosine. Okay, second dose of adenosine is given in double the first dose, that is 0.2 milligram per kilogram with a maximum dose of 12 milligrams. Again given by rapid bolus or rapid push technique. Okay. Now, if the patient is not responding to adenosine or there is no IV access which is available, then what is the next step which you have to do? You have to do synchronized cardioversion. You have to do synchronized cardioversion, which is basically administration of shock treatment. Okay. Now remember, the strength of the shock which you are going to administer starts from 0.5 joules per kilogram. That is the first shock you can give. If there is no response, you increase to 1 joules per kilogram. And if there is no response to that also, you increase to a maximum of 2 joules per kilogram. Okay, very, very important is that you have to start with a low joules and then move on to a progressively higher dose. This is the treatment outline for paroxysmal supraventricular tachycardia. So with that, I have completed the management of narrow QRS tachycardia, namely sinus tachycardia and PSVT. Now moving on to the other side, which is wide complex QRS tachycardia. Remember, the usual category in this wide QRS tachycardia is ventricular tachycardias. Please remember, ventricular tachycardia is a shockable rhythm, as I have discussed in the previous modules. So here again, the treatment of choice is administration of shock in the form of, again, synchronized cardioversion. Here again, the joules administration is the same. You start with 0.5 to 1 joules per kilogram. If there is no response, you can increase up to a maximum of 2 joules per kilogram. Okay, that is the treatment of choice in ventricular tachycardia. Suppose the patient is not responding to cardioversion, then you have to go for drug administration in cases of refractory ventricular tachycardia. The usual drugs which are administered are amiodarone, number 1, and number 2 is procainamide. Amiodarone is usually given in the dose of 5 milligram per kilogram IV over 20 to 60 minutes. Whereas procainamide is given in a slightly higher dose of 15 milligram per kilogram. It can be given intravenous or intraosseous, very important, and over a period of 20 to 30 minutes. Remember, whenever there is a refractory ventricular tachycardia, you can administer these medication, but at this time, an expert cardiologist opinion is recommended, number 1. Number 2, you should not combine amiodarone and procainamide as a routine thing. You have to either use amiodarone or procainamide and wait for expert opinion in this case. That is about the management of ventricular tachycardias. So that is about the discussion of the module on pediatric tachycardias and bradycardia according to PALS guidelines.